He's formally trained in family medicine. He is presenting the principles of evidence-based diagnosis with COVID-19 examples.
Thank you very much. Oh. Go ahead, Mike. Okay. Thank you very much. Yeah, so I think I wanted to take the opportunity to speak you through this afternoon about some of the things that I've learned really in the last couple of weeks about this sort of very rapidly evolving circumstance regarding the diagnosis of COVID-19. And I'm not sure how much I'm going to be able to shed light on some of the confusion and uncertainty. There's a lot more unknowns than knowns about the disease, which also then affects the ability to diagnose the disease. So we'll talk a little bit about some of those uncertainties, and it's in some ways a good example for highlighting some of the basic principles of evidence-based diagnosis, including the idea of a gold standard and what is a gold standard, what's an appropriate gold standard. So the objectives are to review some concepts of evidence-based diagnosis, and then to evaluate, at least to some extent, the current state of evidence regarding diagnosis of SARS-CoV-2 infection, and then apply principles of evidence-based clinical diagnosis to diagnosis of patients in the form of a case or two for whom COVID-19 disease is in the differential diagnosis. So, we've all heard about the test for COVID-19, and that's a PCR test. So a real-time reverse transcriptase polymerase chain reaction, which is also called quantitative PCR. And the current convention is to use the term qPCR to designate that, although you'll see references to RT-PCR, which I think technically is reverse transcriptase PCR, but people use that for real time. But we're going to try to stick to qPCR, or say real-time PCR. And that's now part of all the diagnostic criteria, in the US, the CDC, World Health Organization, China CDC, and other national criteria. And it can target very specifically pathogens because of the specificity of the DNA sequence that it's based on. And therefore, it depends on knowing the genomic composition of the pathogen. And very rapidly, the genome for SARS-CoV-2 was sequenced and has been available since January of 2020. Now, it's important also to distinguish that although it's quantitative PCR, it's being used in these tests for detection of SARS-CoV-2 RNA. So although it can be used for either relative or even more specific quantification, it's being used to detect the presence or absence of the viral RNA. And so PCR in general, and it's PCR in this case being applied to COVID-19, has been really accepted as being, like in this, to quote this recent quotation in a journal article online, due to its incredible sensitivity, specificity, reproducibility, broad dynamic range, and speed of amplification, PCR has been championed by infectious disease experts for identifying organisms that cannot be grown in vitro, or in instances where existing culture techniques are insensitive or need prolonged incubation times. So in addition to some of these practical aspects of the fact that it can identify organisms that can't be identified by culture, and the speed with which it can identify and quantify and detect a viral or other RNA, it's also lauded as being incredibly sensitive, specific, and reproducible. We'll see what that means in a moment when we look a little more closely at the evidence. But for now, so a key question that we're going to talk a little bit about is, like, what does a positive test mean? And that, can mean a lot of different, it can mean a couple different things. And the same thing for a negative test. The first question is whether it's a true positive or a true negative, or a false positive or a false negative. And then the significance of that, the significance of the probability of having a true positive versus false positive, or a true negative versus true positive. So again, the idea that the meaning of the test is in its application to a patient or a population, and then to the decisions that we're going to make based on that. And they'll hopefully will become clear as we go through. All right, so so what do we know about the usefulness of qPCR for COVID-19? So there's been several letters to prominent journals. Most of these are research letters, short reports, in the last couple of months to prominent journals like JAMA and New England Journal of Medicine and others. So this is a report about detection of SARS-CoV-2 in different types of clinical specimens. Most of these reports are from China. This was published in JAMA March 11th. So they looked at over 1,000 specimens for PCR that were collected from 205 patients. So these are repeated repeated samples tested by PCR. And these patients all had to have at least one positive PCR, in order to be considered to have COVID-19. So typically that's along with other symptoms. So the diagnosis isn't based on PCR alone, but with other symptoms. But PCR is necessary to make the diagnosis, and then also in this case with radiology as well. So looking at this table of results, so we have the positive test results in these different specimens. And there's lower respiratory specimens that aren't really the usual, and so relatively few of those. And then sputum and nasal swabs and pharyngeal swabs, which we're doing at the healthcare worker study here at Rutgers, which show then here the positive tests and the percentage of tests that were done from each type of sample that were positive. And we see for like nasal swabs, of the 8 samples that were done, only 5 were positive. Pharyngeal swabs, many more samples, 398. 126 only were positive, only 32%. So this is not the best way to really look at sensitivity, in that it's like test-retest reliability, but it gives you a sense for, if these people had COVID-19 disease and these samples were taken while they were in the hospital, that there were many false negative samples. And so one can imagine that, with perhaps people who are less sick and not in the hospital, having a sample, any particular sample, might turn out to be a false negative. So essentially, these are all false negative samples in these patients who are in the hospital. And so, the proportion of the proportion of true positive samples for all people who have the disease who are tested is a sensitivity. So in this case, that's 126 out of 398 people, or only 32% sensitivity for the pharyngeal swabs. Perhaps a little bit better, but smaller numbers for the sputum and the nasal swabs. So this, to me, was certainly eye-opening. And this is some data from 20 subjects within that study, who had 2 to 6 samples taken actually on the same day or done simultaneously from various body sites. And those show, it's a little confusing or a little complicated here with the different types of samples, but we just look at pharyngeal swabs, the triangles, the orange triangles. We see, quite a few positive samples among these 20 patients, but also, several negative samples, other samples that were negative, particular. They do a lot of other samples, feces and blood and so forth, which are not the usual. But anyway, so pretty clearly that there's false negatives here, and a concern then about sensitivity. This was another study that hasn't been peer-reviewed. It's published online. This was done also in China. 213 confirmed cases of COVID-19, again confirmed by having at least one RT-PCR that was positive, and then having symptoms and signs consistent with a COVID-19 disease. And it's very similarly, this shows, again, and here broken down by severe and mild cases. And then when the samples were taken, either 0 to 7 days, 8 to 14 days, or greater than 15 days after onset of illness, showing again for the typical kind of samples that are taken clinically to assess or do the PCR test, sensitivities, again, retest sensitivity of perhaps at best for the throat and nasal swabs, about 73%, and quite a bit lower in some cases, especially for mild disease, which you might imagine, again, that people with milder disease would be less likely to test positive because of increased likelihood of false negatives due to the fact that their viral load may be lower and less detectable. All right, so then there was another study, looking at how, in this case, one of the points of the study was looking at chest CT and comparing that to PCR. And here again, it's quantitative PCR, though it's referred to as RT-PCR. So here is 51 consecutive patients who had a history of being in Wuhan and exposures to sick contacts, and they had fever or respiratory symptoms of unknown cause, and then eventually, again, had a positive qPCR. And this interesting here is because it was at presentation, all of them had a throat swab, or at least 45, I guess. So I'm not sure what the 45 is there actually now. But all had a chest CT as well. And 50 of the 51 had an abnormal CT consistent with viral pneumonia, but only 36 of the 51, or about 70% of the patients, had a positive qPCR at presentation. So again, this, again, assuming that the ultimate diagnosis is correct. And one of the issues here is that if qPCR is part of the ultimate diagnosis, essentially the gold standard, then actually qPCR can actually be made to look better than it really is, because you're actually potentially, confirming the false positives and confirming the false negatives when your index test is the test being compared to the gold standard test also is included in the gold standard. So again, quite eye-opening. So I included this cartoon here because it's something that I've shown medical students in the past, especially about, raise a point about how if we have a certain frame of reference, that we believe something, it can be sometimes hard for us to change our frame of reference. But we have to be alert to the fact that things might not be what they appear to be when we're doing diagnosis or making other types of medical decisions, and have to be on the lookout for confirmation bias or not being willing necessarily to change our frame of reference. So in this case, this idea that qPCR is, again, such a sensitive and also often called specific test has to be taken into consideration in terms of what that means. And so we'll talk about that. But first, we should talk about what is a diagnosis. So, diagnosis comes from the Greek meaning distinguish or discern. So often we're looking to distinguish between not just health and disease, or normality, something abnormal and something normal, but between different disease conditions. So that, again, can make things difficult, it's complicated. And then it's also the determination of what an illness or problem is, or the nature of the problem. And that's important because a lot of things we do in medicine are about making decisions and actually in the face of uncertainty. And a lot of it has to do with making predictions, like in terms of the ultimate outcome of a treatment or what will happen in the future with prognosis. But diagnosis is really sort of at the root of everything, because we're starting with what actually is. So the uncertainty in diagnosis is uncertainty about what something is, what it currently is, and things about what are going to happen in the future typically follow from the way things are today, the way things are at the present time. So getting a correct diagnosis is then, really fundamentally important for making decisions. But then there are other issues with disease, such as identifying it in terms of pathophysiologic changes, and then sometimes there aren't discernible pathophysiologic changes, and we might have symptomatic illness, such as syndromes. So there are issues in terms of definition of disease that sometimes lead to uncertainty. And we'll talk a little bit about that with COVID too. There are issues with, whether we're looking at asymptomatic versus symptomatic illness, and so forth. But again, so almost all medical diagnoses and decisions start with diagnosis. Whether, again, it's how certain we are is something to consider, but we start with a differential, and we have working diagnoses, then having what we may call a final diagnosis, but we can never be 100% sure of a diagnosis. And then certainly, again, our diagnosis is going to be the starting point for treatment, prevention, prognosis, or reassurance of the patient about there not being a disease or being normal. Another issue with uncertainty in diagnosis is that disease is not static. So most diseases evolve over time, and that's true with COVID, as anyone who's been following some of the news about the again emerging evidence about when the disease starts, when the viral shedding starts, when symptoms starts, when all these things abate, over what time period, and whether or not there could be recurrence now. So it's important to consider that diagnosis changes over time and can change over time due to the evolution of an illness and or disease, and that we have to be aware of that as well. That's, again, a source of uncertainty. So we see that in some of what we know already, or at least what we sort of can model in terms of COVID-19 disease, in which we believe that there's a symptomatic period, and we believe that it's likely that there's viral RNA, or excuse me, viable virus being replicated in the individual during the symptomatic period. But we'll see in a moment, there's new evidence that perhaps that's actually starting quite a bit earlier than the symptomatic phase. But this is the sort of like the typical model, that there's going to be viral replication during the symptomatic phase, but that there could be some viral replication before that, and then there's going to be some symptom onset and then symptom relief, and then afterwards, perhaps after symptoms, there's still some time period where you might find viral RNA via RT-PCR, which may not then indicate a infectious disease, certainly at that point in that individual. So the idea is that if you're looking before the viral replication is really getting underway, at least exceeding the RT-PCR threshold, you may have false negatives, and then again afterwards. But interestingly, very limited evidence here from one of the letters in Lancet, showing that for two patients, the viral load, in this case, attempting to quantify the viral load of individuals at samples that were taken daily at some period after onset, when they first presented, showing the viral load seeming to be peaking at around 5 to 8 days in both cases after onset of illness. But then, curiously, again, one patient here, but suddenly both the throat swab and the sputum samples either not being detected or being detected at very low levels, perhaps indicating like a bad day in the lab. There were, again, the samples were, something happened with them, which we'll talk about in a moment. Or is there something about the viral replication, that's very peculiar in terms of its time course? But again, sort of showing again, in this case, is that a false negative or is that some, true negative due to some biological variability? And then most recently, there's a report, which was published last week, that shows data about viral load, this time measured as the threshold cycle, which is sort of a relative measure of, excuse me, of viral concentration in the samples in 94 patients, showing again, the variability. Each patient is their own, is on a line here, and then it's also showing a lot of values which should be greater than 40 CT values, but showing by a regression that it seems that the viral replication, if this is continuous, was occurring prior to onset of illness. Again, but very limited data here in the early course. But again, showing us what we don't really know about the dynamics of the disease, which may be important for interpreting testing that may be done on either asymptomatic or symptomatic people. So one question is, what is it that we're trying to diagnose? Is it COVID-19 disease or infection? Whether asymptomatic or symptomatic? Because that's going to be very different, as we'll see in a moment, in terms of the diagnostic process, which often that starts first usually with patient's presentation with symptoms. Looking at asymptomatic disease is usually more in the realm of screening. Or are we looking at, again, more serious disease like COVID-19 pneumonia, which then has other signs and test results that may be very helpful? Or are we looking at infectious COVID-19 disease, which again could be either in the asymptomatic or the symptomatic phase, or even post-symptomatic, as far as we know, because again, we know very little about the course of the disease. So it looks like from the evidence that's available that unless, again, there's something about the disease that where there's rapid waxing and waning of viral shedding, which I think would be relatively unique, that there's a lot of false negative results from the evidence that we see so far. So the question is, again, when it comes to false negatives and also false positives, which we know even less about, that there must be some source of diagnostic error. And that leads to either a wrong diagnosis or misdiagnosis, meaning diagnosing something else, or in this case, more likely missing the diagnosis, not diagnosing the disease when it's there, and then also potentially delayed diagnosis. And these all have different consequences. And I guess if I was only speaking to the residents at this time, I'd ask them what those consequences might be in the case of COVID-19. So I think I'll do that. If any of the residents want to unmute and tell us, like, what are the consequences of a misdiagnosis for COVID-19?
I think continued transmission, from asymptomatic patients, to other people in the community.
Right.
Or a false sense of security, a false sense that we're controlling this pandemic when we're not really.
Very good, very good. Yeah, so even though we don't have like specific therapy for COVID-19, which often that would be the case for other diseases. So we don't want to miss a diagnosis, let's say cancer, because we might have therapy that is at least somewhat effective. In this case, it's going to be supportive anyway, but the real concern is about transmissibility or allowing infectious patients to continue to go about their daily business without any type of control. And so that's very important in this case. And again, the idea here too is that because we don't have good therapy, we want to try to prevent transmission as much as possible. Very good. All right, so we just mentioned the consequences of a false negative diagnosis. Again, we know little about false positives in this case, but so what would be a consequence of a false positive diagnosis in this case? Maybe one of the other residents.
Dr. Lombach.
Yes.
I literally, right before another webinar that I began watching at noon, had a patient call me, a patient who I talked to a few days ago. He called me and told me that he was informed that the testing facility that initially did his test called him this morning to tell him that they misinterpreted the test. Initially, they told him it was positive, but when they called him this morning, they said, oops, we're sorry, your test is actually negative. So that created quite a bit of anxiety for this particular employee. And he's been out of work this entire time. And if he is truly negative, now he doesn't really know who to believe. And it's difficult because he's been out of work this whole time. Do we send him back to work? What do we do from here? Where do we go? Do we test him and try to see if we can get 2 negative tests? And if he tests negative, then he goes back to work. It creates a lot of anxiety and confusion for everybody.
Right, very good, very good. Yeah, so there are like real costs or real negative consequences for false positive diagnoses, also. And then I'm not going to go into it too much this afternoon, but there is, I think many people may be aware, there's a trade-off typically between false positives and false negatives, or between sensitivity and specificity, in that for many diseases, there's a cut point that we say above or below which there is a positive or negative result, which if we can move that cut point to make things more likely to be more sensitive by relaxing sort of the cut point, or making it more specific by making the cut point more stringent. So in this case, which would you want to avoid more, diagnosing a false positive or false negative? Again, anybody? Takers?
I think you want to avoid the false negative because you have that false sense of security, whereas a positive, at least that person is quarantined. It's really not a lot of damage done, as opposed to, say, somebody who gets a positive breast cancer biopsy and then they go and get some further surgery. Like the likelihood in this situation is they've just been quarantined. They've probably been extra precautious with family members, with not interacting with people, with social distancing. So in fact, it's probably helped the situation, even if they were falsely accused of being positive, despite some mental anxiety.
Right. Very good. Very good. Excellent. Yeah. So so in this case, the fact that we have such high proportions of false negatives and low sensitivity, apparently, with qPCR, it's a big problem. We know very little, again, about false positives because we don't know a lot about how to rule out people other than with qPCR. So we don't have other studies that have, oh, these are people without COVID-19. But again, in those cases, our gold standard have to not include the PCR test, which we have no other way at this time of sort of ruling out that people are truly negative. Very good. All right. So again, the sources of error can be in the test itself, and that includes the pre-analytical phase as well as the analytical phase of the test. And then also, what's important, and I think has been overlooked to some extent, is in the clinical diagnostic application, which means in applying this test to the people in the real world, what type of results do we get? And again, that should be compared to a gold standard, which one of the difficulties here is that we don't really have another gold standard. So just to review, at the pre-analytical stage, there can be false negatives due to inadequate specimen. So here we have a figure showing what we should be sampling when if someone does a nasopharynx sample, which is to put that probe all the way back to the posterior wall of the nasal pharynx, and to what extent that happens, and we're actually taking a sample from there, and whether we're getting a good sample may vary, obviously. And then there could be, again, biological variability in the viral load in that anatomic area, or in the back of the throat, or wherever we take the sample from. And then there could also be a degradation of RNA due to improper handling. So all these could be contributing, again, to false negatives. On the other hand, again, there's reason to believe there may be false positives due to contamination, not of the sample, but of the sample. Again, people taking multiple samples, there being multiple samples, perhaps, or being in a hospital room where there's environmental contamination, and that may get into the sample. That person in the image there is wearing gloves. Perhaps the gloves got contaminated from another patient. So again, contamination in the sample, but also potentially in the respiratory tract too. If there is viral RNA in the air, then when people are breathing and they're, say, in the hospital again, there may be viral RNA that contaminates actually the respiratory tract, which is not actually necessarily causing an infection. And then there's analytical error. So I wanted to just show a little overview about quantitative PCR and how it works, essentially, to understand a little bit about sort of why it's so analytically sensitive and also specific, and then also what might go wrong with it as well. So the basic idea is that in this case we have a RNA virus. So PCR works on DNA, so we have to do the reverse transcriptase part of this, which is to transcribe DNA from RNA. And so once we've done that, then we can replicate the area of the DNA, the sequence of DNA that we want to amplify because we want to be able to quantify it, or detect it. So the idea is that the qPCR is used to greatly increase the amount of the target DNA so that it can be detected. And so it does this by an exponential process of sequentially denaturing the DNA at a relatively high temperature, which breaks apart the two strands of the DNA, and then using a primer that's specific, actually two primers that are specific to the sequence of DNA that we're interested in, and these would be viral DNA, presumably if there is viral DNA in the sample. So they're very specific sequences that bind to a specific sequence on the viral now DNA, but the complementary DNA that then elongate, because there's a lot of base pairs in this mixture that can then allow the reverse transcriptase enzyme, a highly heat stable enzyme, to do the replication of the DNA. And so then the cycle results then in for every DNA that you start off with, a double-stranded DNA, you're going to produce 2 products, and then from that, again, 2 more products. So it doubles every time, and then so it's exponential in terms of the amount. So after, I believe it's 40 cycles, it's over 1 trillion replicates that you have. And then there's a fluorophore compound that, when irradiated, releases a fluorescence at a certain wavelength, and that's how it's detected then. If there is, again, a replication of this specific sequence, which would be the viral DNA sequence. So the reason for explaining that is because there is an issue or a question about the test itself, sort of how sensitive it is, and how do we call a positive and how do you call a negative result. And so the way that's done is that, so each one of these cycles, again, is a doubling of the DNA fragment. And as that reaction is going along, there's increased fluorescence because of increased replication. And then there's a detector, and it has a certain threshold for measuring the fluorescence. And then once the fluorescence from the reaction exceeds that threshold, then we say you have a positive result. And the CT, or the threshold cycle, is the cycle at which the fluorescence exceeds the threshold. And this should happen in this exponential phase. And it's also set, quite low, just above like a level that might be background fluorescence. And then as you have more and more cycles, that's really increasing the sensitivity because, again, you're producing more and more replicates of the original RNA. But if you get to the point, usually the convention is greater than 37, then the results are questionable, because then you have like artifact formed that causes fluorescence, and it's not considered to be reliable pretty much by convention, at that point. So this is just another plot of that, showing, again, there's a detection limit. Your threshold should be above that. And then this is for 3 different reactions, showing that once the amplification, the fluorescence exceeds the threshold or meets the threshold, then it's that corresponds to that, which is your CT, or CQ in this case, which is another labeling convention. So within the assay itself, there's a lot of control in terms of positive and negative controls, and then typically there's more than one target, typically 2 or 3, and then you must have typically a CT of less than 37 to be positive. And then it's typically, again, by convention, most of these assays are run to 40 cycles. But between 37 and 40, it's usually considered, if there is some exceedance of the threshold between those CT values, then there's reevaluation done or retesting. And then there's positive controls as well as negative control. So the assay itself is very sensitive and specific. As declared in that quote that I said earlier, and that, so analytically it's very sensitive. But again, there could be false negatives analytically as well if there's inadequate RNA isolation, because you can have inhibition of the assay enzymes, which slow the reaction down. The assay itself may just be poorly developed in terms of the primers, for example, or other elements of the assay. It's relatively simple, but also has some complexity. And then it's a poorly run assay. Again, any type of sloppiness or whatnot can lead to false negatives. And then also a single mutation, even in the primer sequence, in the virus, can lead to changes in the melting point when the sequence is heated up again to separate the strands. So that can also be an issue in terms of the quantification, especially. And then you can have false positives due to cross-contamination from positive samples, again, other samples being run on the same instrument, and then, again, non-specific artifactual fluorescence. So problems occur during the analysis, but the big issue is that there really is no clinical diagnostic sort of testing to know whether or not, again, what the true sensitivity and specificity of the test is in certain populations or groups of patients. And so, as with other tests, we know that there's variation anatomically, physiologically, and biochemically, both between people as well as within individuals over time, and that there's a lot of, overlap typically, or at least some overlap between variation that's normal and disease, or between different diseases, again, in a differential diagnosis situation where we're looking at what distinguishes one disease from another. There can be overlap in the things that we might use in terms of tests, especially for continuous variables. But PCR has become the de facto or reference gold standard for many viral infections. But again, it hasn't been evaluated really in clinical diagnosis. And then the situation currently, is that there's been rapid deployment of various COVID-19 tests, because mostly what we heard about testing early on was that there weren't enough tests, and really didn't hear anything about whether the tests were good or not. And so now the questions about whether the tests are good are starting to come to the fore. But it's really like a situation that's sort of like the fog of war in terms of like the uncertainty. And then, to carry that analogy a little further, it's really, you really don't know what the enemy is up to, because we really don't understand, again, the natural history of the disease yet. And we don't know a lot that we'd like to know about issues like viral shedding and when it occurs, and how much viral shedding, or how much essentially virus RNA, what that actually means. So we typically, don't rely on single tests to make diagnoses, and that's a good thing. We start with what's often called pattern recognition, where we can sometimes instantly recognize a likely diagnosis. But then we may also be more thoughtful and generate hypotheses and a differential diagnosis. And then in terms of rational clinical diagnosis, we at least intuitively, if not quantitatively, assess the pretest probability of each potential diagnosis. And then we do diagnostic testing, which then can help us to refine our likelihood or our certainty about a diagnosis in terms of the post-test probability. And then we may try a therapy, and then we also would reevaluate afterwards. So, in terms of a threshold concept for diagnostic testing, we're never really sure enough. There's never absolute certainty, but we can be sure enough. And in some cases, we don't need to do further testing, clearly. And it depends on the outcome of treated versus untreated disease, the transmission of detected versus undetected disease, in this case, very important. And then again, the consequences of false positive or false negative tests or diagnoses. And then issues about the benefit, risk, and costs for not only the treatment or the diagnosis, but also of the diagnostic test itself. So we're never really absolutely sure. The probability of a diagnosis is always somewhere between 0 and 100%. And this is a model that sort of helps to formalize thinking about what we're doing when we go through a diagnostic process, that there's a test threshold in which we think we're below which actually we can sort of say that we are going to reassure the patient or consider other diagnoses. And then a treatment threshold above which we say we don't need to do any more testing. We're sure enough, we have enough certainty to treat the patient. And then in between, there's a zone of uncertainty where we should do more testing. And the idea here again is to sort of sometimes think, well, maybe we don't need another test. We only need another test if we're in this zone. If we already are confident enough about the disease, maybe we don't need to test. And this is important then for COVID-19, where again, if someone has pneumonia and they have a fever and they live in an area where COVID-19 is epidemic, they've had contacts, then maybe we don't need to do even a PCR test. Or if we did and it came back negative, it doesn't mean anything to us anyway. So again, we want to sort of move that threshold by doing tests, and we're going to do more testing only if we're in the zone of uncertainty here. And there's, again, various reasons why we might consider more testing depending on, again, the costs of false positive or false negative diagnoses, as well as the costs or potential harms of the testing itself. So we again want to move beyond those thresholds. I just mentioned those things. So for clinical diagnostic reasoning for COVID-19, we're going to start with our pattern recognition, hypothesis generation, differential diagnosis. So we have a case of a 59-year-old male who lives in New Jersey. This is back on March 10th, 2020. Presented to us with cough, fatigue, chills, and body aches for 3 days. He doesn't know if he had a fever. He has no history of respiratory disease and not traveled internationally. His oral temperature is 99.5. His pulse ox 100. His pulse 100, pulse ox 97. His lungs sound clear. What's your hypothesis? And what would you do next? We just, in the interest of time, is going to go on to some of the answers, perhaps. So one thing we heard early on with COVID-19 was, like, if someone has a fever, that's important. If you don't have a fever, then you're unlikely to have COVID-19. And again, this goes back a ways, but so this is actually published back in JAMA on February 7th. So again, early on, a report showing that again in the hospital, 138 patients in Wuhan, 99% of them had a fever. So so that's useful, and that's useful in the sense that a very sensitive test, when it's negative, you can essentially rule out the disease. As a rule of thumb. But a little bit later, another report from China, among 1,000 patients, only 44% had fever when they entered the hospital, and although 89% developed fever while in the hospital. But again, we're talking about at presentation, what your decision might be about in terms of your certainty of a diagnosis. And then, so it raises the question also about, again, as an example, about the sensitivity of a sign or symptom, that if in the hospital is actually quite specific, and a more sensitive way, again, where there's a trade-off between sensitivity and specificity. A more sensitive, perhaps, measure of fever is fever or chills at home, or fever on presentation. Again, just to raise that issue about the relative sensitivity or specificity of a sign or a symptom or a test. All right, so then our case, we might consider like a rapid influenza test. Back in early March, there was still some flu around, so let's say that was negative. The patient returns 3 days later, now with a fever and chills for 2 days. A chest X-ray shows increased markings consistent with interstitial pneumonia. And testing for COVID-19 by qPCR is now available, and you do that test, and lo and behold, the test is negative. So how does that test your management? So any comments on that from anybody? Any of the residents?
It may be some sort of bacterial pneumonia.
Right, so that's a possibility, certainly, right? So it might truly be a true negative test for COVID-19. And so you might want to do like more testing for bacterial pneumonia, right? As well as maybe provisionally say, well, maybe it's a false negative, so let me not rule out necessarily COVID-19, right?
Could it be another viral pneumonia? Or
it could also be another viral pneumonia as well. Like there were reports of positive influenza tests with people who also, were diagnosed with COVID-19 as well, and certainly could be independent of that.
Oh.
But the general idea is you wouldn't necessarily rule out COVID-19 probably in this circumstance, right?
You'd probably want to test again, or at least quarantine the person.
Right. And certainly could test again. So this is a little quote from Epictetus, who was a Greek philosopher about 2,000 years ago, who sort of got it right about so how we should think about tests in terms of, in this case, when he refers to appearances, we can replace that the results of a test. Appearances to mind or the results of a test are four kinds. Things either are what they appear to be, which would be true positives, or they neither are nor appear to be, and that's true negatives, or they are and do not appear to be, that would be false positive, or they are not, they are and do not appear to be, that would be false negative, or they are not yet appear to be, that would be false positives. And rightly to name in all these cases is the wise man's task. So how do we do this? So how do we know what's real? And there's certainly philosophical arguments of how we can know anything is real that go back to at least Plato. But in our case, the way we usually do this in medicine is relying on a reference standard for being, again, reality. But again, we don't necessarily always know that the reference standard is appropriate or reflects reality. And so that's the case also with PCR, which has become, again, the de facto reference standard. But obviously, again, looking at it, not compared to another reference standard because there isn't any, but looking at it in terms of its retest reliability, at least, that it looks very faulty as a reference standard. But that's what we would like to have, certainly, is a reference standard which can tell us when people do or don't have a disease, and then we do our tests, and then we get results that fall into those four categories of Epictetus. And the important thing is, again, to find an appropriate reference standard or to use an appropriate reference standard, and to always keep in mind when you hear test results or in terms of their sensitivity and specificity, was the reference standard appropriate? And so, reference standards then are typically, are very objective results like a biopsy, even, at autopsy, although of course there can be errors in biopsy diagnosis as well as autopsy, surgical exploration, etc. And often we're using the reference standard to compare to, that's like our best method compared to other tests that may be more accurate, but more likely are either safer, less costly, more timely, easier to perform, more acceptable to the patient. Because we have an issue if we're just trying to determine the accuracy. If we're more accurate, we're going to look actually less accurate than the reference standard if the reference standard is not as accurate as the index test that we're trying to assess. So, I think I'll leave this to the residents. Maybe we'll go over some other time like some of the ways that we assess false positives, false negatives, and assess sensitivity and specificity and positive and negative predictive value and likelihood ratios, because I think we're running out of time. But suffice it to say that, so these sensitivity, specificity, and likelihood ratios are properties of the test. So again, we're assessing these, we're determining these when we essentially test a diagnostic test, and then we can apply that these values, especially likelihood ratios, to a pretest probability, which is independent of the test. And using likelihood ratios, we can multiply pretest odds by the likelihood ratio to get a post-test probability. We'll do that more formally some other time. So again, if our patient has a chest X-ray now that has, and then a CT of the chest that shows characteristic ground glass opacities, which are not thought to be specific to COVID-19. As the residents just mentioned, there are other causes, bacterial or viral pneumonia, that may look very similar. So it's not thought to be specific, but can it be sensitive? This results from one study showing that, indeed, in terms of sensitivity, it's very sensitive. In patients who are in the hospital, though, with serious disease, that most of them, by radiographic review by 2 radiologists, were quote unquote diagnosed with having COVID-19 disease. Again, in an area where it's very epidemic, but again, not very specific. So the specificity is 25%, with sensitivity 97%, as we discussed. So, so there's more here in terms of looking at the likelihood ratio, but we'll go over that some other time. And just to finish up, so qPCR does not look to be currently adequate for ruling out disease, and the ruling it in, or the specificity is not clear either. But there has been hope that potentially serology or measuring the response of the host might be a helpful specific response, the antibody response, either IgM or IgG. And this is, again, a preprint, not reviewed, of a serology test from China that looked at a series of patients and showed that the IgM or IgG increasing with a positive rate, getting up around 80% by about 10 or 11 days post onset of symptoms, and overlapping with a viral RNA by, again, qPCR. So indicating that this might be useful even during infection. But there are other models indicating that IgM, the earliest immunoglobulin specific that's being produced, may or may not overlap with actual disease, so may not be very useful, certainly, to diagnose a disease. So in summary, analytical sensitivity should not be confused with diagnostic sensitivity. The diagnosis of COVID-19 is challenging due to a lack of a reliable reference standard. The limitations of RT-PCR are apparent from the results that we have so far, especially low sensitivity of a single test from the upper airway, which has become, again, the gold standard for diagnosing COVID-19 disease, whether in asymptomatic or symptomatic people. And a more sensitive test is needed to better control spread of the infection. But whether that's possible is a question. And then specificity is relatively less important as care is supportive, but again, as we discussed, there could be unnecessary burden on patients from unnecessary self-isolation. And then also, there may be other diagnoses that are responsible that aren't treated when we assume that PCR rules out other diseases. So any questions? Questions or comments? Okay. Yeah, so I think at some later date, maybe we'll talk a little bit more, I'll talk a little bit more with the residents about likelihood ratios and pre and post test probability.
Well, Rob, I want to ask a naive question. Maybe not.
I can hear you. It's a little echo, or a lot of echo, but
A lot of echo. My question is, we hear a lot about this quick saliva test that's been developed in Newark, and that they're going to test 10,000 patients, I think was the last I heard. I mean, 10,000 subjects, sorry, individuals. Where does that fall in all of this in terms of, I don't know much about it, but, you know, can you just comment on that test? Do you know much about it?
yeah, so my understanding from what I read about it is that it was compared to pharyngeal swab tests, and that I believe it's the same test, or maybe another saliva test, but a saliva test that I heard about was being compared to pharyngeal swabs. You know, again, so the idea being that the reference standard then was the pharyngeal swab, the throat swab, which again, in some evidence that's available, indicates that the sensitivity might be very low for that as well. Yeah, so then it's likely that the saliva test, even if it is matching the throat swab results, is also has poor sensitivity, which means there's going to be a lot of false negatives. And there's going to be, in the general population at the present time, if this is used for like wider sort of screening, which is questionable to begin with about whether or not asymptomatic people, clinically at least should be screened. Like certainly random testing to sort of assess the spread and the dynamics in the population of the virus is important, but people getting tested just to determine if they have an infection when they have no symptoms, they may be negative today but positive tomorrow. It's quite questionable how useful that is.
Thanks. This is really helpful.
Rob, one of the things about the saliva concerned me was, we were hearing that the ACE2 protein was found mostly in respiratory epithelium, which is why sputum seems to be more sensitive. So I was concerned from the very beginning about saliva and false negatives. Do you know anything more about that?
Yeah, so I think, that's example two of, certainly, I think from the limited evidence available, including some of the data that I showed, the lower respiratory tract specimens were more sensitive, more reliable, retest. But there's a question there about the trade-off, right? Issue that the big trade-off there is that you maybe give up some accuracy because you don't want to be doing procedures like bronchoscopy that expose healthcare workers to aerosols that are known to be generated during that type of procedure. So even sputum, is typically not thought to be, wise in doing testing with symptomatic people. Yeah, so that's definitely true, and so that might be an example. Limited evidence we have, and also if more study was done of the gold standard to do more lower respiratory tract sampling.
Also, another point, early on we heard that a false negative rate, and I don't know which test this was associated with, but I assume it was a swab, was around 30%. However, they found that 2 false negative tests, 24 hours apart, the false negative rate dropped to 9%. Can you talk about the false negative rate and multiple samples?
Yeah, so I think in a simple case, like the tests have to be independent of each other, which is, I think, always a question about that. And then one could actually just, sort of multiply the percentages, right? That they're independent probabilities, so 30% chance of a false negative, and then 30% of that 30% if you repeat it, right? So now we're talking about a 10% false negative rate if they're independent. But I think one question about that is, even the 30% false negative or 70% sensitivity, what is that based on? Again, is it just like the data I show, which is the test, retest, or is it actually in, what's the gold standard for knowing if the person is truly negative? Repeated testing. I mean, they could do like 5 tests negative, to get closer to knowing that the person is actually negative. So I think that definitely, repeating the test, and that's basically the idea of the data from the studies that I showed about the final diagnosis in those cases was typically at least one positive qPCR, and which might be called believe in the positive test. So any positive test, which then raises a question: well, if there are false positives, is that accurate then? And again, the idea that we don't know about false positives because we have no other way of ruling out the disease than the PCR test itself.
And isn't it also possible that a lot of people who are, theoretically don't have very serious disease may never have had COVID at all? Even if they got tested, it may not be accurate. And so maybe they're pretty asymptomatic or have only minor symptoms because the test was wrong, or it's like we maybe not think. Go ahead.
No, go ahead. Say again. Sorry.
No, I just was going to say we may not even be thinking about this properly then, if all the, a lot of what's going around is saying that these people who are, have the disease and are carrying it or giving it to other people, but they're primarily asymptomatic or very minor symptoms, but in fact, maybe they don't even have the disease.
Yeah, well, I guess, again, the idea, it's interesting, like with the qPCR is that, again, it's being used to detect any virus with confidence, analytical confidence, and then if it can detect any virus with analytical confidence, that is then, a positive test, and that, again, with symptoms, I think is supportive, because it is very specific, right? So when it's positive with symptoms, assuming that it's specific COVID and there's no contamination issues and all these other things that might cause false positive, but that's what we call like a spin, a specific test that's positive rules in the disease, which is then useful, right? But if the person doesn't have all these other doesn't have symptoms, doesn't have signs, hasn't had contacts and so forth, then even a relatively low rate of like false positive might be very important. Like that's what we see when we do like screening in populations where the cancer, for example, where the incidence or the prevalence is very low. Then even a very low false positive rate, a very specific test, is going to yield a lot of false positives. But when we just don't know, I think, again, the whole viral shedding thing, this idea that anybody who has a positive test for detection of viral RNA is shedding. I think I'm not a virologist. It's not not my area. I'm not an infectious disease doctor, but to me, it seems like that's a question, and that's a question early in disease. It's a question in asymptomatic disease, and also maybe like in the convalescent phase too. Just because you can detect viral RNA, does that mean the person is infectious? I don't know, but I don't know if anybody knows.
Thanks.
Okay, any other questions, comments?
Rob, in the study that they're doing downstairs, they're taking saliva, they're taking a swab, they're taking blood. This, I don't know why there's an echo. Why is there an echo? The saliva is actually very hard to do and takes a long time, and they're making us keep the little tube under the hood. How is that possible to be able to do that in a setting where there are a lot of people close by? How are they going to do that?
I don't know. That's a good question. I haven't done it, so I'm not sure what it takes, but all right. I think so. You're concerned about potential like contamination.
Yeah.
Yeah. So so again, the idea that with the usual PCR assay, you're creating 1 trillion replicates. And there's questions about like what's the actual detectable number of replicates and so on. But even so, the idea that potentially very, very few original RNA strands might cause a positive result. Again, we don't. It's hard to know. And again, the idea is that these things have to be sort of tested in the real world in order to really know. And there hasn't been anything like that done.
So, Rob, we're going to go through this all over again with the antibody tests.
Right. Yeah, I mean, one could think, well, maybe, having both can be helpful, right? I mean, sort of like what Mike was asking about, repeating the same test twice, but one could actually think about having one has 2 different tests which again are assumed to be independent, right? Like a serology and PCR, that can be very useful. It might also be useful in retrospectively, determining who's a true case and who's not, by again the combination of the PCR and the serology, which again the serology should also be very specific. Although, like we know from our experience that people can have antibodies to things that they weren't infected with, right? When we talk about like fungal antibodies, for example, and I actually was reading something recently about someone proposing that the pneumonia, the COVID-19 pneumonia, is more like a pneumonitis, and actually likening COVID-19 quote pneumonia to hypersensitivity pneumonitis. But anyway, that brings to mind that there are responses that people may have where perhaps they never were infected, but they have an immune response. Right. It's that I think that brings up a question then too about what does it mean to be infected, which again, I'm not a virologist or an infectious disease specialist, but it seems like at least for some people that might be a question. Any other comments? Or? Okay, well, thank you very much, and look forward to seeing you all again sometime soon.
Thanks, Rob.
Take care. Bye-bye now.
Thank you.
Thank you.
Very nice talk. Very nice presentation.